I alluded to there's some limits and issues and you know, practical issues sometimes, I mean, to get access to the CAR T cell and so on and so forth. But what do we do to try to make it better? So as you alluded to these ASCO data, there was a small experience on a retreatment. Can you retreat those patients with CAR T? And the reasoning behind this is that there's some evidence that, you know, these T cells do not stick around long enough. There is some discussion and that on the need or not to have persistent CAR T cells. We had about 1/3 of the long responders in the ZUMA-1 that did not have persistent, long-term persistent CAR T cell and still in response. And we can see that with the recovery of the B cells that we see, and even immunoglobulin after a year or two, after a year mostly, we can see that therefore the CAR T cells have disappeared. But there's also the idea that some patient relapsing, can we retreat those patients? And this was a small number of patients that were from the axi-cell setting, and over half of the patients achieved a response, 4 CR, 3 PR, so again, small numbers. What was interesting is that some of these responses can be durable up to close to 3 months, up to 225 days for the longest. There was a comparable rate of CRS at the retreatment, but it seems there was less neurotoxicity and maybe also less CAR T cell expansion. We don't really know exactly on how to read this, but this is feasible. This is an interesting question, and that is being explored as some of the trials. Can we do repeat, you know, infusion of CAR T, and that's potentially one strategy. The other one that you alluded to is that can we improve by bringing the CAR T earlier? And that's the question of the timing of the CAR T, right? So if we do the CAR T cell earlier in the second line, and there's the ZUMA-7 that is completed, the results are pending, but there's other studies with liso-cel and tiso-cel looking at also at the second line and with a crossover. So in second line therapy, randomizing against salvage and transplant. And here, this was interesting study from Gordon Group and looking at liso-cel in patients who are not transplant eligible. And it is an interesting study because liso-cel potentially less an easier toxicity profile, so might be easier to do. I'm sorry, it's a slightly different product when the CD4 and CD8 subtype of T cells are prepared separately and diffused separately. They get the same Cy/Flu lymphodepletion. And what was impressive in that study, not a huge number of patients, but the overall response rate was 89% and the CR rate was 56% with very low toxicity, and 12 out of 29 patients were done as an outpatient. So this is really important because that offers potentially an option for these non-transplant eligible patients. It's early for the durability, but I mean, I think this is something that is to take into account. At ASCO, there was also data on the dual CAR T anti-CD19 and CD22 in combination with pembrolizumab. And that's a very interesting study called the Alexander study. And the rationale for this is that patients, there is a subset of patients in large cell lymphoma that become resistant to CAR T because they lose CD19 expression, something we see more frequently in ALL as a mechanism of resistance than in large cell lymphoma, but still happens. And then so combination, the dual CAR T, CD19, CD22, and with pembro to try to see if we can improve the, knowing that the checkpoint blockade is also one of the mechanisms of resistance, can we improve the responses seen? And this is dose escalation, not a large number of patients, but the response rate was very high, and 10 of the 11 CRs, a small number again, are still ongoing. There was no grade 3 CRS and 1 grade 3 neurotoxicity, and the recommended phase 2 is 150 to 450 million, and with day 1 pembro selected. And then the last study that I think is worth really mentioning at ASCO was the allo CAR T cell off the shelf. That is a product called Allo 501. So it's a gene editing based technology using the TALEN technology to remove the T cell receptor and CD52. And then this is used as also as a dose escalation presented by Dr. Nilappu and showing a response rate of 63% with half of these patients being in complete remission. And in a patient, 75% of the patients who responded were still in response at the time of cutoff. So that's also interesting because there was no GVH, and there was one concern because those are allogenic healthy T cell. There was no dose-limiting toxicity, 1 grade 3 CRS, and no neurotoxicity. And that's very, very appealing because it will be off the shelf, ready to go CAR T cells, and potentially something very important because one of the factors of failure of CAR T is the T cell fitness. Patients who are heavily pretreated, have a lot of immunosuppressive environmental milieu with their active disease, ongoing lymphoma. These patients don't have necessarily the best amplification and the best activity. So if we have a normal fitness like allogenic normal T cells, that might address that problem. And the last aspect that is also important is that it was from ASH, but this is the BiTE antibody, because we know that patients still can fail quite a bit CAR T cells. And it was an anti-CD20 bispecific antibody, BiTE antibody presented at a plenary session at ASH, and it was very, very impressive because this was a response rate of 39%, 22% CR, but there were some responses durable, CR durable in continued remission, even in patients who had stopped therapy after 16 months of treatment. So this is also being explored in a frontline setting in combination with chemotherapy, CHP Polar versus R-CHOP. So there's a number of initiatives that are trying to address the unmet need the new unmet need that we have in CAR T cells. Now we know how to manage more toxicity. Can we improve on the efficacy and look at easier ways to use those CAR T cells?